Hello, this is Teresa Vaz speaking from Valencia, Spain. There is Saturday lunchtime. Wherever you might be, thank you very much for joining us today for this important 5 webinar on grant outcomes. We are excited to hear all the speakers, and we received the research grant in this past year and sharing with us the outcomes. I am co-hosting this session with Michelle Marks. All of you know her, and she's a research director of the Sitting Scoliosis Strain. Before continue, I would like to thank Scoliosis Research Society for promoting and sponsor research and innovation. For the audience, please follow this important webinar. Remember to use the question and answer feature. Please limit your question for engaged and deep understanding of the whole research. Now, I don't want to speak more, and I would like to introduce the first presenter, Dr. Ishan Warren, who is going to present a preoperative patient expectation in patients undergoing spinal deformity surgery for adolescent idiopathic scoliosis. Thank you, Dr. Ishan.
My pleasure. I'll share my screen. Okay. All right. Good morning, everybody. My name is Ishan Swaroop. I'm a pediatric orthopedic surgeon at the University of California, San Francisco. I appreciate the opportunity this morning or afternoon or evening, depending on where you are, to present our work. So as Dr. Bass mentioned, the title of our project was Preoperative Expectations in Patients Undergoing Spinal Deformity Surgery for Adolescent Idiopathic Scoliosis. My disclosures are listed here. So as a background, as many of us know, adolescent idiopathic scoliosis is oftentimes associated with curve progression, and in some cases can also be associated with pain, body image issues, and cause a lot of psychological distress in our patients. In general, in the orthopedic literature, there's a fair amount of data and research now which suggests that greater preoperative expectations from patients oftentimes results in better outcomes and improved satisfaction after surgery, especially elective orthopedic surgery. And in various other subspecialty orthopedic subspecialties, there are validated preoperative patient expectation surveys. For example, the one that's shown on this slide here is the one for ACL surgery. There's also others that exist for adult spine surgery and also shoulder surgery. However, there are no expectation surveys that have been developed in pediatric orthopedics, specifically pediatric spine surgery. So the whole kind of background of this idea was, well, if greater expectations result in better outcomes and meeting expectations results in more satisfaction after surgery, can we potentially modify expectations so that we can improve outcomes and satisfaction of patients undergoing surgery? So the aims of our study were really threefold. The first aim of our study was to develop a validated and reliable measure of patient and guardian expectations relating to posterior spinal fusion in patients with adolescent idiopathic scoliosis, and then subsequently determine what factors are associated with preoperative patient expectations for AIS patients undergoing surgery. And then lastly, use the survey to assess the relationship between preoperative expectations and outcomes and satisfaction. For the purposes of this grant, our goal was really to achieve aim 1, which was to develop and validate a preoperative expectation survey. We hypothesized that patient expectations relating to spinal deformity surgery can be reliably quantified in patients and guardians. And we also hypothesized that patients and caregiver factors will be associated with preoperative expectations. And then lastly, we, in the future, since this is an ongoing study, we hypothesize that expectations will be related to outcomes and satisfaction in patients undergoing posterior spinal fusion for AIS. So the way we did this is really in a couple of different phases. So phase 1 was first to identify expectations and assemble the survey. So we used the existing methodology that exists. Majority of it has been described by Dr. Carol Mancuso from the Hospital for Special Surgery, where I was a resident. And so we used a lot of her methodology in order to first identify expectation and assemble the survey. The first phase was really done using 15 patients and open-ended questions, which I'll talk about briefly in the next couple of slides. Phase two was really validating the survey with another cohort of patients, another 15 patients, and caregivers to see whether this is a reliable survey. And phase three, as I mentioned, is the ongoing part of this study right now, in which we are prospectively administering the expectation survey as well as patient-reported outcomes to assess the relationship between expectations and outcomes, as well as expectations and satisfaction. So speaking a little bit more in detail, so phase one, which is a survey development, we essentially asked open-ended questions of patients and caregivers in order to develop the survey. In phase two, we wanted to validate, and in phase three, we are collecting PROs, and the PROs that we're collecting are listed there. They're mainly SRS-22, SF-36, PROMIS physical function scores, as well as various demographic and clinical characteristics of the patients as well. So since this grant really applied to phase one, I want to speak a little bit more about what we did in terms of the interviews. And so for these interviews, we really utilized the same format that's been previously described for expectation surveys, where we would ask questions, and the two questions we would ask are, what do you expect as a result of you or their spine surgery, depending on who you're talking to, whether the patient or the guardian? And are you or they after you or they have recuperated from surgery, what do you expect to be different? And oftentimes, just these two open-ended questions allowed us to really understand what patients and caregivers expected from their surgery. And then these surveys or interviews were recorded and then transcribed. And then once we did that, we had the assistance of one of our qualitative researchers here at UCSF to help code these interviews into various themes. And so we identified themes that emerged from these interviews. And what we found was that, the expectations tended to be repetitive after the first couple of interviews. And so that's why 15 seemed to be the right number. And so we were able to identify various themes that were emerging for both patients and caregivers. And from that, we were able to develop a draft survey. And then for the validation phase, we took the survey that we had, we ensured that we had it written in a reading level that was appropriate for the population that we see, which of course, according to the AMA, we try to aim for these to be around the 6th or 7th grade reading level. And then we performed test and retest reliability, in which we administered the survey to patients and caregivers and then re-administered them a few days later to ensure that these were reliable measures. So this is the survey that we were able to develop. So again, 15 patients were used 15 patients and caregivers were used in order to develop the survey. The average age of our patients that assisted in the development of the survey was around 15 and a half years. Majority of them were female, typical of an AIS population. And then you can see the questions are listed here, but the majority of them were, I would expect a straighter spine. I would expect to be pain-free. I would expect to avoid medical treatments in the future related to my spine. I would expect to fully participate in sports without restrictions. I would expect to be confident in my appearance. I would expect my posture to be overall improved. I'd expect to be able to sit longer, stand longer, expect to be taller, expect to have a full recovery without any mobility or appearance issues after surgery. And then we performed in the validation phase. We took another group of 15 patients and we administered the survey roughly a week apart. And what we found was that there was at least fair agreement in all of these expectations. And actually the highest agreement was noted for the ability to have a full recovery and the ability to participate in sports without pain or restriction. So those seem to be consistently important expectations for patients. And then for caregivers or guardians, on average, their answers were more consistent, and they had a moderate to higher agreement for most of their expectations. One of the things we are looking at is how much concordance is there between patient and caregiver expectations, which I'm not going to share too many of the details of that today, as it's beyond the scope of today's talk. But what we have been finding is that there is somewhat poor to moderate correlation between what patients and guardians are expecting, which will be another future direction of our study. So in discussion, it is possible to quantify preoperative expectations for AIS patients undergoing post-spinal fusion, as well as identifying preoperative expectations of their guardians. There is fair to great agreement between baseline and validation surveys. However, patient and guardian expectations may not be well aligned. The results of our study will hopefully eventually allow surgeons to better counsel patients and their guardians to align expectations and potentially affect outcomes and satisfaction after an elective procedure. The weaknesses of our surgery are the fact that, of course, we are limited to one center in one geographic region of the world. And also, currently, the survey is validated only in English. We are working on making this validated in other languages as well. And the next phase, as I mentioned, will be to assess what factors associated with preoperative expectations, as well as correlate expectations with patient-reported outcomes, surgical outcomes, and patient satisfaction. I'd like to thank my research team, which is comprised of various residents and research staff listed here. And of course, I'd like to thank the SRS for funding this research. And thank you.
Thank you very much, Dr. Swarm. And now I can open the questions and answer, please. Congratulations. I like very much your talk. And I have one question. Is do you find different expectation between the social level, the education level, and race level in your work?
Yeah, that's a very, very good question. So in general, so we first of all, we try to, you know, survey patients and guardians from kind of all socioeconomic backgrounds. So, you know, in our inclusion criteria was very broad. And just based off our patient population here in San Francisco, you know, we have a fair mix of private and public payer patients. And so we have a very representative sample. We have not gone into those details yet, which is to try to stratify, you know, what are the predictors of expectations, and that is kind of the next phase of that of this study. And so the current phase, which has significantly more patients that we're enrolling, that is one of the things we're going to look at is, does educational background, does socioeconomics affect expectations? Because in the other studies that I mentioned, for example, the shoulder expectation survey, those were significant predictors. And so I think that will be something interesting and we'll be looking at in the future.
Thank you very much. We have another question from Stefan Parent. And he asked that for the 15th patient to you select, where they are different background medical pathologies, how can we measure that they represent the population to be treated?
Yeah, great question. So the patients that we included in this study were obviously we included patients under the age of 18, all with a diagnosis of AIS. So we excluded other diagnoses, you know, no early onset scoliosis, no syndromic scoliosis. It was all a AIS population. Within that, since we are kind of a tertiary care center, obviously, you know, you have healthy AIS patients and you have unhealthy AIS patients. And so we do have a spectrum of patients that were all included because I think, as you know, you're alluding to, expectations may differ also based off of medical complexity. So yes, we have a variety of a representative sample, but in general, our goal was to have patients with AIS and including comorbidities or not.
And the last question we have is from Dr. Walter Turon. And Dr. Sang, what do you expect to be the type of intervention that made the biggest difference in managing expectation and affecting outcomes, please?
Yeah, it's a great question. Thanks, Walter. You know, I think in previous studies, what has been shown is, you know, modulating expectations is kind of like an interesting topic. And so what most people have found is that the informed consent process is kind of the most important time to set expectations, both from a positive and a negative perspective, right? You're obviously talking about risks, but you're also talking about benefits. And I think what people have found is that if you set appropriate expectations for patients, the thing that you can certainly affect is satisfaction, right? And of course, satisfaction is hard to measure, But that is something more reliably that you can maybe affect with understanding expectations and potentially modulating expectations. Other studies have shown that patients that actually do have higher expectations leading into surgery tend to have better outcomes. Now, there's various hypotheses of why that might be. And so that, may be an opportunity for us to um, also coach patients that may not have high enough expectations of what's about to happen so that there is more of a, they have more of a positive understanding of what's about to happen, what they're about to undergo, and potentially that could, affect positive change. Hopefully
Okay,
that answers.
and
Yeah.
sorry, another question too. Have the patient involved have a screening for pre-existing anxiety or other psychological comorbidities, please?
Mm. Yeah, good question. So, no, unfortunately not. So we do not administer any kind of psychological testing, and in fact, like I mentioned for the earlier question, we did not screen for any underlying psychological or psychiatric illnesses. I'd have to go back and look, but of course, I'm sure we have a few patients that have underlying either a mood disorder or other underlying psychiatric diagnoses, but we did not screen for that.
Okay, thank you very much for your work, for your answer, and we are going to move to the next um speaker. He is Dr. Kenny Wan, and thank you to be here. And he is going to show us effectiveness of three-dimensional correction during bracing in adolescent idiopathic scoliosis, a prospective randomized clinical trial of Rigaud Chenot versus Boston style orthosis. Thank you, Dr. Kenny Yan, and you can start.
Thank you, Teresa. Just as a disclaimer to start off, this is not finished, so this is ongoing. But I've been told by SRS that I can share my tribulations and pains of running an RCT. I will share with you some results as well. So I'd like to thank the SRS for supporting this work. So the idea came from really this landmark study looking at the effects of brace success. And this brace success, despite good compliance, is only around 70%. And the failure rate is measured by the reaching of the threshold for surgery or requiring surgical fusion. But if you look at the traditional factors that affect brace success, most of them are not really modifiable. So there are already patients coming in and seeing you with these things that you can't change. So the traditional brace that we use in Hong Kong is like a Boston style type of CAD/CAM TLSO brace, which uses this padding and also three-point system to try to correct the coronal curve. But pretty much the sagittal and the rotational profile is determined really haphazardly. Now, the Regal Chanel brace is another brace that is quite popular, but not quite so in Hong Kong. And it really uses a derotational effect and also has room for the spine to derotate by correcting the spine. So which also applies a slightly different system in controlling the curve. And you can see that the force is slightly different with regional derotation of the spine occurring. So most of the existing studies surrounding this brace is retrospective, so there is not enough robust evidence to support the routine use of this brace. So with the focus on improving the rotational profile of the spine, could this be more effective in controlling curve progression? So we thought we could do a randomized controlled trial to control the brace and everyone who satisfies the SRS criteria for bracing and look at the effect and following them up until skeletal maturity. And based on the previous published trials and systematic review, we calculated that we need about 134 patients in both arms, taking on 15% attrition rate. And now there were many problems actually when I first started running this trial, and these could be divided into one in fabrication of the brace and two in the recruitment. So just look at the fabrication of the brace. So in order to start the brace, so our authors have all been trained to do just the TLSO brace initially, and eventually they have been also sent to train this regal brace. But they haven't had any practical experience, so they need to relearn all the bracing criteria and the curve types. Now, the brace design, we actually have someone who is qualified to overlook the designs. So that wasn't too difficult. But in order to make sure that we were not inferior to what we are actually providing as a baseline to our patients, we actually did some trials. So you can see that this is a trial of the brace design, both on our CAD/CAM system and actually in fabricating the brace, and also had some fitting sessions with our patients. Now, the problem then is we needed to fabricate both braces for these patients to make sure that we are not inferior in treating these patients and know how to fabricate the brace. And the first problem actually came from these brace materials and thickness. The authorities actually alerted to us that using different thickness and different synthetic material can actually have an impact on the effect of curve control. So in order to eliminate any bias on the brace, we then had to go through quite a few different material and thickness in order to be sure that that in itself will not create a bias in the RCT. So we went through quite a few material that we could find, and we had to do quite a few trial. And also in the trial, we actually found that the different thickness can also affect the original TLSO brace that we were doing. So it actually made some of the braces fabrication time much longer and a little bit less comfortable than the other brace. So we had to go through further trials with different patients before we even started the control trial to make sure that this effect is not a source of bias when we're doing this, and it's not too thin or flimsy, but it's not thick enough that it causes bracing problems. So in the end, we had to go for a compromise that allows adequate time and also adequate thickness that is efficient for our orthosis and also useful for controlling the curve. And so this was the final design and the final thickness and the final fabrication time that was deemed enough, and it's not too flimsy, particularly for our original bracing. There's also a cost issue as well, which I also did not think of when I was designing the trial initially. So because of getting all these new material and stuff, it turns out to be a little bit more costly than I had thought. Now, the second issue that I ran into was a recruitment issue. So initially, it was quite easy because we were only one of two quaternary referral centers and tertiary referral centers. So all patients with scoliosis had to be screened and had to be sent to us. But at the start of the trial, all the scoliosis screening clinics were closed in Hong Kong because they were all used to administer vaccinations in Hong Kong to patients. So nobody was screened, nobody was sent to our clinic. So we had a bit of a problem in recruitment. Then COVID finished, and so you thought, okay, well, patients will start coming in. But the problem was we were seeing the backlog of patients who were not screened. So meaning that they were not identified early enough, and a lot of the patients who came in subsequently had very severe curve or rather late into the skeletal age that they were no longer suitable for bracing. So not only could we not recruit them, they were not even suitable for bracing. So this also led us to have some delay in the recruitment issues. Now, and also because of the backlog of the approved trials, we normally run multiple trials of bracing, but it is not ideal to enroll the same patient into multiple trials. So we also have to rationalize to make sure all the ongoing trials that have been approved can restart. So it meant that the number of patients who are suitable for bracing will then have to be allocated to different trials. So that also was not ideal in the recruitment. But nonetheless, if you have the heart and if you want to run an RCT, you have to soldier on, and we did. And COVID finally finished, and patients started coming back, and screening was on full screen. And after 1.5 years of starting this study, we finally finished recruiting all the 134 patients that is needed. And so we're now finally on the follow-up phase until skeletal maturity, which in my experience can take up to 5 years. Okay, but anyway, I have some results to share with all of you. We have some patients who have reached the 12-month interim analysis. So based on the 12-month interval, we actually have 25 patients who have passed the 12-month interval, 13 in the traditional braces and 12 in the RCO brace. We did a primary or interim analysis to make sure that we're not doing any harm to the patient. So we just took the x-rays out and blindedly sent to an independent assessor and a statistician to take a look to make sure that the two groups are comparable. And we found that in the interim cohort analysis, the baseline of these two groups were comparable. They were of similar age and similar gender and similar skeletal maturity, which is what the RCT is supposed to do. And the follow-up time, the mean brace wear hour was reasonable between the two groups and slightly comparable. So the change of Cobb angle was actually not as stark as we thought it might be. So if you looked at the percentage of patients who had improved or stable Cobb angle, they are very similar. And the patients who have deteriorated Cobb angle, they're very similar. Mind you, this is only 1 year post-brace. Normally we'll have to wait till skeletal maturity before we can make a definite conclusion about the effectiveness of the brace. But at least I can say at this time, one brace is not worse than the other, so we're not doing any harm. And the mean change of Cobb angle over time is also kind of similar between the two groups. The only slight difference that we thought we saw was that there was some change in the pelvic obliquity between the groups that were undergoing the RCO comparing with our normal traditional brace and after brace initiation. So it may be too early to conclude anything right now, but at least we can say that there is some change in the pelvic obliquity in the coronal alignment of these patients who are wearing RCT, which may have some implications in the end, as there are some papers showing that the pelvic obliquity correction may also ultimately lead to a better balance of the shoulder. But we'll have to wait and see until probably up to 3 to 5 years when all the patients have reached skeletal maturity before we can conclude whether one brace are better than the other. At the moment, we can only say that it is not inferior to the traditional brace that we have provided to our patients, which is our standard of care in Hong Kong. And so we'll continue this RCT and we'll report to the SRS when we have the results available. So I just want to thank everyone for their help in this brace. So I'm open
Thank
to...
you. Thank you very much, Dr. Kenny Wan. And we have a lot of questions, short of time, but I would like to ask you first question. And why you don't check the hand? And where is the location of the curve? Lumbar, thoracic, and what is the flexibility of the curve that you can tell us that is better one or the other? And what is the importance of the pelvic obliquity for the correction of the deformity?
Yeah, so we have hand X-ray for all patients. In fact, that is what we normally use in Hong Kong. And so I briefly abbreviated that as what we call the DRU classification, which is published by Hong Kong. So that is our standard for measuring skeletal maturity.
Okay.
But we don't have time to show you that. Now, for the flexibility of the curve, it's also published by us in Hong Kong that our gold standard of an adequate brace is that so we take the supine film of every single patient who comes in. So that is the gold standard that we make our brace no worse than the supine flexibility of the curve. So we don't take a fulcrum for that. We take a supine film. So we don't use an arbitrary 50% flexibility for the effectiveness of the brace. So the brace has to reach the supine flexibility or better in order the orthotist will pass it back on to the surgeon to review. If it does not reach that supine flexibility, they need to refabricate the brace until it reaches that. So automatically flexibility is gold standard in our hospital.
Please, Dr. Tom Schroeder, could you ask to Kenny one?
Hi, Kenny. Great that you are taking the efforts for the performing an RCT and bracing patients. So I've actually two questions. So in your title, there is that you measure the three-dimensional correction in both braces. Can you explain a bit on how you do that? Because you're now talking about cup angles.
You're right. So the initial interim analysis, we have not done 3D reconstruction of both. So ultimately, what we want to show, and that was actually the initial aim that we will show at the end, is that we are actually constructing using EOS 3D profile of every single spine at every single interval that we get the X-rays. And so we will be able to correlate the brace success rate with the ability of the curve. Because, actually, in my previous study that I've shown, some of the Boston TLSO type brace actually inadvertently also controls the 3D profile of the spine because of the coupling effect that has been shown by us in Hong Kong. So if you correct the coronal profile, the sagittal and the rotational profile will automatically couple. But it doesn't occur in every single case with the TLSO brace. But I've previously shown in another study that for those who had rotational correction shown by the EOS, they have better rate of brace success. So what I want to show in this study, or well, what my hypothesis is actually of this study is that if RCO really has a better rotational control and will be proven by the 3D recon of the EOS, whether the brace success actually is due to that or not.
Please, next, Dr. Brian Snyder.
Hi, how are you?
Hi,
So
Snyder.
being from Boston, so I have to tell you the Boston brace actually has evolved. So in fact, we now employ 3D concepts, and actually we use off-axis derotation couples. So the standard Boston brace that John Hall invented in 1970s, we've evolved way past that. So in fact, we use 3D concepts and think about the deformity actually as a helical coordinate system as opposed to a Cartesian coordinate system. And actually, you want to apply often your apex of your derotation couple at the apex, which is often in an off-axis way. It's like the old Stagnara plane. If you think of this as principal planes, the principal plane of deformity is not in the Cartesian plane, it's in the helical plane. So what you're calling Boston brace is from the 70s. That's not what we do now.
So is there a new name for your brace? Because when we refer to the Boston brace, people will think of the original brace, right?
Yeah. No, we think 3D concepts are really super important. That in fact Rigo Chanot, I think, has to be credited. But we're starting to evolve our thinking that a brace is an external form of growth modulation, and that if we think of it as a growth modulation type device, that instead of a tether applied internally, it's an exoskeleton system. And then you want to start looking at growth modulation. And most of the deformity, as you know, happens at the disc and the soft tissues. So we want to capitalize on taking advantage of those viscoelastic components.
Sure. So should I call it a 1970? Should I?
Well, it's the old concept. I think the important point that you're trying to make is think about three-dimensional changes that are multi-axial, and then just like you're right, it's coupled movement, and this lumbar joints versus the thoracic because of the orientation of the facets, and the rib cage also have different coupled movements, from the basic biomechanics. So I think your important point is you have to think three-dimensional. And I think that's super important.
Thank you very much to for the speaker and all the question. And remember, any question we don't get to live, the speaker send to the type the answer in the queue and answer test. Thank you very much. Sorry about the delay. We now introduce Dr. Jordan. He's going to speak about new strategies for pulmonary assessment in spinal and check wall deformity. This is a standard a grant of the Scoliosis Research Society. Thank you, Jacob Jordan.
Hello, my name is Jacob, and I'm a Penn medical student and a year-out CHOP research fellow, and today I will be presenting in place of Dr. Cahill. I'd like to thank my collaborators, the Center for Thoracic Insufficiency and the Functional and Metabolic Imaging Group for contributing to this work. So, no relevant disclosures. So jumping right in, early onset scoliosis is defined as curvature of the spine that develops before age 10. But as we know, it's not only a disease of the axial skeleton, but of the lungs as well, as a result of the thoracic constriction. Due to spine and ribcage deformity, these patients develop postnatal pulmonary hypoplasia and restrictive respiratory disease. And studies show there's a 300% increased mortality compared to AIS. Decreased pulmonary function is a consequence of two things: mechanical inhibition of the chest expansion and the respiratory pump, in addition to compromise of mature lung parenchyma. Treatment, of course, is focused on creating more space in the chest and optimizing thoracic growth, but challenges we face today are that more adequate assessments of lung function are needed to inform optimal interventions. And PFTs, while the standard, only provide a global assessment and can't tell us exactly where ventilation is compromised by deformity and whether those areas have improved after surgery. So to address this unmet need, we propose to evaluate innovative imaging techniques that can measure respiration and ventilation resulting from this thoracic deformity. With the help of our partners at the Functional and Metabolic Imaging Group at Penn, we identified hyperpolarized xenon MRI as an imaging tool that could give us some of these further insights into pulmonary deficits and thoracic insufficiency. And it's a technique that utilizes diffusion information of inhaled xenon gas to assess lung pathology. To accomplish this, the gas is first passed through a hyperpolarization machine where nuclear spins of the atoms are aligned, and that enhances the MRI signal by a factor of 100,000. The central basis is that xenon can be used as a surrogate marker for oxygen transport and is soluble in the body. And it has resonances of xenon as a gas, xenon bound to lung tissue versus xenon bound to blood, are distinct and can be tracked over time and space. And this allows for regional analysis of gas exchange rates and efficiency, with some of the data garnered being used to generate functional maps, as you can see here. Already used in other areas like ARDS, COPD, lung cancer, and fibrosis, as in this image. We implore to ask if this can be used in thoracic insufficiency as well, where we would hope to see the impact of disease pathoanatomy. And here you can see the yellow arrows indicate areas of deficit in terms of oxygen and xenon uptake to the blood. So we feel that there are many clinical advantages to this approach, which I've laid out here. This technique is completely non-invasive, it's radiation-free, safe, and provides regional information that we can't get from standard pulmonary function tests. And most importantly, it also provides an alternative set of objective data that can be used by surgeons to inform operative decisions and evaluate responses to interventions. So moving on to our methods for this study, to investigate the impact of early onset scoliosis pathoanatomy on lung development and pulmonary function, a rabbit model of TIS was implemented, which was developed by our co-investigator, Dr. Brian Snyder, who is on the call today. Unlike rodent models of lung growth and pathology, rabbits and human lungs grow similarly, developing greater than 90% of their alveoli after birth. When the ribs of these animals were tethered in early development, lung hypoplasia was induced, thus validating the rabbit model can effectively evaluate clinical impact of TIS pathoanatomy on pulmonary development and function. So in our study, constriction of the right hemithorax and spine deformity was induced by tethering the rib cage of 7 6-week-old New Zealand white rabbits, and we had 2 additional rabbit service controls. Following that procedure, repeat CTs were taken at 6 weeks, 26 weeks, and 2 years postoperatively to measure lung volume and monitor the progression of the spine and thoracic deformity. Hyperpolarized xenon imaging was then performed at 30 weeks post-op in a control to measure the difference in alveolar septal wall thickness, which is calculated from dissolved phase, xenon gas dynamics, and multi-breath acquisition. A gas mixture of 20% oxygen and 80% hyperpolarized xenon was administered for 15 breaths at 6 milliliters per kg tidal volume. So moving on to the results, as far as the anatomic characterization of the model, surviving rabbits exhibited Cobb angles of 20 to 62 degrees, which didn't change after maturity. And you can see here representative images taken at 6 weeks, 26 weeks, and 2 years at the 2-year post-op time point. Then as far as our xenon imaging results, as you can see on the left with the representative plots, the gas phase and dissolved phase signals of xenon were measured separately in each lung in the thoracic insufficiency rabbit and control rabbit over multiple breathing cycles. So in the above plot, the rate of reaccumulation of xenon signal during gated breathing was analyzed by our imaging research partners, and that was used to derive changes in alveolar septal wall thickness between the groups, essentially being derived from the diffusion equation. And what was observed was that the physiologic septal wall thinning that is normal in humans or in rabbits was retarded in the TIS rabbit, or thoracic insufficiency rabbit, which is significant because septal thinning and subsequent capillary restructuring are critical for normal lung maturation and function, and when altered, imply impaired gas exchange. The constricted lung had an alveolar thickness of around 18 micrometers, while the contralateral lung, untethered lung, so to speak, in the same rabbit had a thickness of 14 micrometers, and then however, the alveolar thickness in the unoperated normal controls was around 12.5. So looking below, you can also see plotted the dissolved phase and gas phase signal ratio in the thoracic insufficiency rabbit and in the control. And this tells us the tissue volume to alveolar volume in the lungs, and what was observed throughout the respiratory cycle was that the dynamic ratio was 20 to 80% higher in the TIS rabbit than in the control. And that tells us essentially there's less alveolar space and the thoracic constriction that leads to diminished ventilation. So taken together to conclude, hyperpolarized xenon can elicit changes in alveolar septal wall thickness in constricted lungs and help document impaired gas exchange in these regions. And this will help us to better understand how structural anomalies are associated with impaired respiration. However, while we were able to successfully measure gas exchange dynamics in the previously established model, there were notable limitations with using rabbits. 4 of our rabbits died during the course of our study, with the high mortality risk being associated with repeated anesthetic events during serial CT and xenon imaging. Additionally, the resonance spectra of the xenon bound to tissue versus xenon bound to blood is not optimally differentiated in the rabbit, which makes analysis and tracing of gas exchange more difficult. Based on these limitations, future directions include potentially making a pivot to using an alternative model. And the LAM has shown to be particularly interesting as it's a larger model, which has proven to be more resilient to repeated anesthetic events, has greater similarity in size for pediatric comparisons, and offers the spectroscopic advantages as the xenon frequency shifts for xenon attached to tissue versus xenon attached to blood offers greater separation than the rabbit. So when comparing the xenon resonance spectra across species, you can see these differences better graphically. Red arrows show the xenon resonance bound to hemoglobin, which in humans is around 216 parts per million. And then in blue, you can see xenon attached to tissue, which is around 196. The LAM spectrum in panel B shows a lot of similarity to humans with clear separation between the two resonances. And the advantage this provides is that we can get greater specificity into where oxygen is going and the efficiency of gas exchange. Looking at the rabbit, the peaks are essentially merged here, and it's hard to differentiate spectroscopically. Therefore, the only information we're truly able to garner is the xenon bound to tissue and not that additional information of xenon bound to blood, and therefore telling us about gas exchange. So this differentiation is particularly important in thoracic insufficiency, where we hypothesize that both ventilation mechanics and alveolar capillary gas exchange may be compromised. So overall, very excited about this new potential direction. So wrapping up, just want to thank the Scoliosis Research Society for supporting this project. Working with Dr. Kale and Dr. Snyder as mentors and the rest of the team has been an amazing experience thus far. And I'm very motivated to pursue a career in orthopedics. And Dr. Cahill couldn't, of course, be here, but is also grateful to the SRS and the many relationships and collaborations he's been afforded. So yes, thank you. And I guess now we're open for questions.
Thank you very much, Dr. Jordan. I appreciate very much your talk, and I would like to ask you, do you know how can this technology influence my surgical decision in patients with thoracic deformities?
Yes, so the idea is that normally when you have PFTs, you're not able to truly correlate the improvements in anatomy to any improvements in lung function. PFTs have a poor correlation and can even often decline after surgery. However, what this technology is potentially able to help us understand is what kind of improvements can we see beyond just lung volumes? Can we see improvements in actual gas exchange? And at what point can we see that? So ideally, we would be using this technology to compare different interventions and different time points in intervention to tell us, are we improving pulmonary function at a level greater than just ventilation, so actual respiration?
Thank you very much. And there is someone who wants to ask something for the panel. I have another question. What were the main limitations in the rabbit model, and how you can improve this limitation?
Yeah, so the main limitations were essentially what was the fragility of the animal. When you have repeated anesthetic events, when you try to intubate these animals multiple times, they just have a higher mortality risk. So none of the risk was associated with any sort of surgical procedure or anything of that nature, but they're just incredibly fragile animals. So that was a complication, and we aim to resolve that using essentially a more resilient model, a larger animal. However, the compromise there is that while rabbit lungs are very similar to human lungs, lamb lungs are a little bit less similar as their alveolarization is complete at birth. However, we still believe there's a lot of advantages in moving towards the lamb.
The last question, if it's okay with you, what are the advantage of this hyperpolarized xenon 19 over the traditional methods we have?
Yes, so I guess the traditional methods being PFTs, do you mean?
Yes.
Yeah, so PFTs are essentially giving you a global assessment of lung function. They're telling you that your ventilation and respiration may be compromised, but not telling you exactly what components of your lungs are contributing to this. So by giving this greater specificity and better detail into what exactly is malfunctioning in the lungs, we can, I guess, essentially target strategies better to either one side of the body versus the other, or one side of the lungs versus the other. So that regional detail just gives us better understanding of the pathoanatomy of the disease, and just allows us to, I guess, better target interventions.
Okay. Thank you very much, Dr. Jordan, congratulations. And I think to say thank you to all the speakers for the effort and the time in this presentation. And I would like to introduce Michelle Marks. She's going to hosting the next session. Thank you, Michelle.
Thank you, Dr. Vass, for this great moderation of an incredible first part of this session. And I have the honor of introducing Dr. Paige Little from Brisbane, Australia. It's after midnight there, so we are very happy that she is willing to participate, and we're looking forward to her presentation. Thank you, Dr. Paige.
Excellent. Let me just make sure. Okay, so I should be sharing screen now, I think.
Yep.
Excellent. I'll push on. All right. So firstly, I would just like to acknowledge the very significant contribution of all my co-authors. As always, none of these things are an individual's effort. So this was definitely a team effort, and particularly the senior author, Dr. Jeffrey Askin. So quick disclosures, we were very grateful, authors Little Askin, Isaac, Lebron and Suresh, to receive a 2022 Scoliosis Research Society grant, which partially funded the salary for one of our co-authors, Sir. We also were lucky enough to receive a Queensland Children's Hospital Research and Education grant, which also partly funded co-author Sir. Other than that, my salary is funded by something completely different from Celia of Australia, which has nothing to do with this project. So as we know, AIS patients require regular medical follow-up to monitor deformity progression. And this is particularly the case during periods of accelerated skeletal growth during puberty. Timely monitoring of progression is essential in referring timely treatment. But for young patients in rural and remote areas in a geographically dispersed continent such as Australia, receiving timely specialist care is particularly challenging. So to address this challenge, we have been developing new e-health technology to remove some of these barriers for remote families to receive specialist care by enhancing the tools that are available to deliver telehealth appointments. So as we found, COVID has been a game changer for us all for remote health delivery for spinal specialist care. And there's a lot of really great papers that came out post-COVID around this, but they highlighted the lack of physical examination of patients and the inability to perform functional tasks using the current telemedicine technology. In the context of scoliosis, these relate to the inability to see the cosmetic deformity associated with the radiographic findings and the inability to perform diagnostic functional tests, such as the Adams-Ford bend test to measure axial trunk rotation. So conscious of these gaps in existing telemedicine technology, we started to develop digital technology to enable the surgeons to see the patients virtually while they're in their own home and to interrogate a little bit more about functional tests. So we developed a free smartphone application that allows parents and caregivers to capture 2D photos of the patient using principles of structure from motion. The photo capture in the app includes some assistive AI to help mum or dad or the primary caregiver position the patient properly for the photos. And then the photos are then processed using photogrammetry methods to create a 3D digital model of the patient. In these models, we are particularly interested, as you can imagine, in the spine and the torso asymmetry. From these models, we then measure clinical metrics which describe the external deformity. So here you see examples of the axial torso rotation calculated using our semi-automated digital algorithm. This was published by my postdoc, Dr. Suresh, a couple of years ago. And then the metrics are visualized by the spinal specialists in a digital patient file to augment the telehealth appointments. So in this file, the surgeon sees, in inverted commas, sees the patient via a geometrically accurate 3D model, and they can see the metrics that were calculated from the algorithm listed as well. The really important question with anything like this is, can we trust the tech? I'm an engineer, so I'm inherently untrusting of new tech. So we set out to answer that question. To do this, we recruited 20 AIS patients from Spinal Outpatients Clinic at the Queensland Children's Hospital. It was a retrospective study design, and patients received their standard in-clinic appointment, at which time a manual assessment or measurement of axial trunk rotation, or ATR as I'll refer to it, was made. But in parallel to that, photos were captured using the smartphone to create a 3D model of the patient, from which digital measurements of ATR were also calculated. So as we know, ATR has been shown to correlate significantly with deformity progression. So evaluating accuracy and reliability of measurement of ATR for remote health technology was a very keen focus for us. To determine accuracy, we compared the clinical and digital measures of ATR, and we found mean axial torso rotation was 15 degrees for both of the groups. There was a strong positive correlation between the clinical and digital measure, which was significant. And the Bland-Altman comparison of means showed a mean difference between digital and clinical measurements of 0.8 degrees. The limits of agreement on this were +5 to -5.5 degrees. And we're pretty happy with that because that's around about the measurement variability for axial torso rotation in clinic. An important part of this as well is the treatment concordance. So this is, first of all, we assessed a measure of the digital assessment, so whether the digital assessment method provided the same management advice as the in-clinic appointments when measured by the same surgeon. And then secondly, whether the digital measurements were repeatable between surgeons. So the same surgeon provided the same management advice in clinic and in a mock digital assessment for 85% of the patients. Now, those ones that differed tended to be somewhat similar outcomes, whilst our categorical outcomes, we had 7 different outcomes that we were assessing. We were quite strict in whether or not one or the other was the outcome measure. So, for example, for one of these patients, one of the assessments suggested post-bracing. The patient should come back for a review in a couple of months, I think it was 3 months. The other assessment, 6 months later, they could be discharged. So they're not exceptionally different outcomes, but they were classified as different outcomes. The other was the intra-class correlation between the 3 surgeons, all using digital technology, was excellent, 0.9375. So where to from here? Results to date have been quite positive. We've had really good feedback actually from the surgeons indicating the technology improved their remote healthcare delivery experience. They were keen to use it. And it reduced patient appointment time, which was very nice in a public system. Surgeons found technology very user-friendly, and the caregivers actually were really positive about the impact that it would have for their child's care. These are remotely based parents. Our approach is novel in Australia, to some degree internationally as well. It creates better connectivity for the patient and the surgeon by allowing the surgeon to see the patient, but while the patient's in their own home. But further clinical validation verification is still underway. And we see the technology having significant impact in the future to improve access for both remote as well as urban-based patients. I'm sure Brisbane is no different to any other major city where it's quite a hive of activity and a very busy space in the public children's hospital. So if we can avoid families and children having to travel in there, even from one part of the city, it would be advantageous. It has potential to reduce the system demand and also to reduce the healthcare costs for both the patient and the department. That's me. Thank you.
Thank you so much, Dr. Little. Congratulations on your grant award and on the work that you're doing. I do have a few questions that were been submitted, but why don't I let Dr. Swaroop go ahead and start with his question?
Great. Thanks, Dr. Little. This is really interesting work. I mean, it's kind of taking surface topography to a different level of actually measuring ATR, which I think clinically is helpful. My question relates to the standard error that you have, right? It seems quite broad still. I mean, yes, we're talking 5 to 6 degrees, but what I'm trying to figure out is how do you use that clinically, right? So if you have these serial pictures that show you ATR, so what is your cutoff to say that, okay, this child should probably come in for an actual in-person evaluation or an X-ray when the standard error is so wide, so to speak? So I'd love your thoughts on that.
Sure. In terms of the standard error, I have to be honest, we have set out with a pathway of reproducing the current state of care. So we didn't necessarily set out to improve it. We set out to provide a benchmark. In the future, we hope to improve it. So that's probably the first answer to that. And secondly, because of the nature of, so these kids will come into hospital for all of their management appointments, and we don't necessarily want to replace some of those crucial appointments. Just to explain a little further, what we want to do is tap into some of those appointments that might be, for example, for a patient will always come in for their first appointment, but then there may be follow-up appointments that don't have an enormous amount of progression between those two. So those are the ones that we want to tap into. And then they'll always have later preoperative appointments, potentially appointments where bracing is required, because they would probably have to have those in Brisbane. But some of those ones in between are what we're trying to tap into. So we haven't necessarily looked at those error margins in terms of a cutoff for deciding whether a patient would then need to come into clinic for care. We've at the moment focusing on a status quo and working to that.
Got it. Thank you.
Thanks.
Thank
Okay,
you.
so I have a question from Dr. Stefan Parent, and he'd like to know, how do you see your technology evolving for both screening and monitoring of curves? And then a second question, did BMI have any impact on your results?
What a good question. BMI always has an impact on surface scanning. Yeah. So in terms of how we see it evolving, in the initial part, our vision has solely been to try to provide geographically equitable care to children living outside of highly populated metropolitan areas in Australia. I'm in Queensland, and for anyone familiar with our geography, it is one example of several states which are very broad with a lot of travel time that children all come in to service, to a public service which is in the metropolitan. So currently evolving would be to service Queensland and ultimately Australia, and we have some lovely partnerships with other clinicians within Australia. This may be a romantic vision, but I would love to see this having impact in third world countries that have an enormous number of patients in their clinics, which it's just hard to see. One of the PhDs actually in our group is from India, and she's been doing casting in India. And she said the amount of patients that they see, you just can't get through any clinic. So we would love to be able to see this assist with further equitable care in other countries. And then the third thing, that's a fair point, Kenny. And then the third thing is ideally we also do a lot of bracing work in parallel. So I was very interested in Kenny's paper, actually. So we're working with a lot of bracing in terms of digital orthotics, in terms of the idea of using topographic scanning to digitally design and then to manufacture. So ideally, we would love to try to lean into some patients to try to tap out and not have to travel 15 hours to come and get a brace either, which is a very real thing that patients are doing here in Queensland. Overnight to get into Brisbane to receive and running. We get it through the system, and it's in the public system to maybe take it that next step further, and then and perfect even further our 3D scanning from the photogrammetry to assist with orthotic treatments too.
Awesome. Yeah, thank you. And Dr. Vass, you have a question?
I would like to ask you if, congratulations, but this technology is useful for kyphosis too, or only for scoliosis?
You've given me a new idea. We haven't used it for kyphosis. Thank you, Dr. Vass. Perhaps collaboration moving forward. In truth, the concept of the technology has enormous impact. So I've had colleagues who are neurosurgeons. I've had colleagues in the craniofacial who are interested for vault surgery. Anything that involves something topographic, scar monitoring, wound healing monitoring, anything that involves something that can be measured from an external shape, shall I say, has utility. And also in terms of the digital algorithm has been developed by my post. Dr. Suresh is a genius. So she's developed this for scoliosis. Similarly, could be developed for other deformities as well. So there's huge potential. At the moment, we're trying to get it into the system for scoliosis, which is proving a little bit of a problem in a juggernaut of a public system. But we hope that we can have impact with other care as well.
Okay, thank you.
Wonderful. Okay, one last question. This is from Dr. Gomez. Great work. Do you agree that a clinical sign is more useful than the X-ray? I think he's referring to ATR and having some concern without having an X-ray.
Thank you for asking that question, Dr. Gomez, actually, because an important part I haven't mentioned is that patients remotely receive radiographs. 100% we are not replacing the radiograph. As was referred to earlier, there is BMI is a consideration, as Dr. Parent mentioned. There are various considerations around use of topographic scanning. So patients will still be referred regionally out in Roma, Charleville for their local X-ray, but the doctors can get that in Brisbane. So they still don't have to travel 14 hours into the hospital. So those are used in parallel, hence why we're creating comparable to the current standard of care, which would have an X-ray and a physical exam. The phone is the physical exam now.
Got it. So are you doing any work into correlating that those findings, the scans and the X-ray?
That has been suggested actually, because that is something definitely that there is a decent amount of work on in terms of using the 3D surface scan in place of an X-ray. I think it's just some of those limits that I feel a little nervous about at the moment for larger patients or very small range curves. I've also heard the argument that, well, if you catch any of them, then it's good and it doesn't matter. So we probably will look to actually incorporate algorithms. We have looked at those algorithms, by the way. We just haven't incorporated them in this particular app to correlate surface-based curvature with X-ray POB traditional measurements.
Got it. Thanks. Well, it's exciting work. Thank you so much.
Yes, Kenny.
What was that, Kenny's comment?
Sorry, do you still have time?
Yes, please go ahead, Kenny. Sorry, I didn't see your hand.
No, that's okay. No, I was just wondering, actually, rather than correlating, rather than making it replacing the X-ray, you may actually be able to define a new cutoff for your program as a screening tool. So it won't replace X-ray, but you may be able to see what the actual cutoff is with your tool, and then combine with, other tools may actually give us a higher sensitivity and specificity for screening in the future.
That's a really good point.
Because I think ultimately, when they reach a certain threshold, you probably will still get an X-ray to prove whether they are over, a certain number of degrees, and then refer to the tertiary hospital. So it doesn't have to replace X-ray.
Yeah, that's a good point. Thank you.
Great work. Okay, we got to move on, guys. We have our next speaker, Dr. Tom Schlosser from the Netherlands, is taking time away from a skiing trip in Austria to present to us today. So thank you, Tom. Go ahead.
So can you see my slides?
Yes, we can. Go. Perfect.
Yeah, so I would like to thank the SRS for the new investigator grant to study the value of MRI-based navigation in pediatric spinal surgery. But actually, we didn't perform pediatric spinal surgery. We mostly did safety studies in cadaveric settings. So thanks to the SRS. Most radiation in AIS patients or pediatric deformity patients at all comes from the pre- and intraoperative imaging. Actually, 1 in every 1,000 AAS patients, they develop cancer because of the radiation involved with navigation surgery. And definitely the surgically treated patients, they receive a higher effective cumulative dose. So every form of spinal navigation requires 3D imaging, either intraoperative 3D imaging with 2D or 3D devices, or pre-op 3D imaging and some form of intraoperative referencing. So a pre-op 3D imaging is normally a CT scan, and the intraoperative referencing can be performed in several ways. It can be anatomical landmarks or point cloud surface matching, can be automatic surface matching, it can be a registration based on 2D fluoroscopy, or it can be 3D printed guides that match the patients. But all these imaging methods require quite some high doses of radiation. So what is left if you do not want to use radiation? Actually, only those 3 referencing methods, but you need a different imaging technique. And for the current studies, we used a scoliosis-specific MRI protocol that can be used for synthetic CT generation. That's a special 3D MRI sequence, which is our RF spoiled sequence, which looks a bit like a T1 sequence. It takes about 5 minutes. At the moment, already a little bit less, and it can cover 42 centimeters in the sagittal plane and about 15 to 20 centimeters in the coronal plane. Then a convolutional neural network is converting these images into a synthetic CT, so a true CT with Hounsfield unit. So this is different than, for example, the zero echo time MRIs that are also used for bone-like images obtained with MRI. So this is an example of the 14-minute multipurpose scoliosis protocol that we also now use in our clinic. It is a combination of a 3D T2 sequence, actually covering the thoracic and lumbar spine, but also covering the cervical spine. I left it out. And it covers 42 centimeters of the bone MRI, which are the second and the third image. And those second and third image, they are combined, converted into the synthetic CT that also allows the 3D reconstructions. So the aim of the studies we proposed for this new investigator grant was to test the safety and the accuracy of MRI-based synthetic CTs as the input for spinal navigation and whether that is non-inferior to conventional CTs. This was investigator-initiated, but of course we had to collaborate with navigation companies to test it. So we used commercially available spinal navigation system with a point cloud surface matching, and we performed a preoperative MRI with synthetic CT reconstruction and also preoperative conventional CT, and we randomized those. We did that for the cervical spine and for the thoracic and lumbar spine. So we performed navigated pedicle screw placement in 5 cadavers from C2 to L5. Half of them were synthetic CT guided, half of them were CT guided. We actually placed 230 K wires with an international team of 4 surgeons, all randomized for surgeon, for the modality that was used, and for the left and right of that cadaver. This is what the planning looked like. On the left one is a bone MRI. On the middle one, that is actually a post-op CT where you see all the air artifacts on the cadaver, and this is what the planning looked like before surgery. So the outcomes, we had no pedicle breaches over 2 millimeters for any of the 240 K wires. So the method actually looks quite safe. However, this Gertzbein-Robbins classification is quite tricky because it really depends on the size of the pedicle screws that you put in. If you always put very small screws, you never have a breach. So we standardized the pedicle screw sizes, so all were 5.5 screws in the thoracic and lumbar spine, and all were 3.5 screws in the cervical spine. So we had no severe pedicle breaches in any of the K wires that were placed. And also we superimposed screws on those K wires to see whether we had no breaches, and still we didn't have any breaches more than 2 millimeters. But I think this is actually more important for any navigation study. That's the true distance of the entry point and the maximum angle between the place screw and the final screw position. So the mean distance was around 2 millimeters, 2.4 and 2.3 for the conventional CT and for the synthetic CT, and the mean maximum angle between the pre-op planning and the post-op position of the K wires was around 4 degrees for the point cloud surface matching. For the cervical spine, this was more or less similar. So we had accuracy of around 2 millimeters, which is in the cervical spine maybe quite high. So it should be debated whether this is accurate enough to place safely cervical pedicle screws, especially when the pedicle is small, the vertebral artery is close, and the spinal canal is, of course, close. So it really should be weighted for each indication. For CT guided placement as well as synthetic CT guided placement. And then the average angular errors were around 5 degrees, but no differences between the imaging modalities. We recently performed also a cadaveric study for 3D printed guides. The white ones are in-house printed guides in our academic facility. The yellow ones are commercially available 3D printed guides. And also there we didn't see any difference between the 3D printed guides based on synthetic CTs or MRI-based synthetic CTs versus conventional CTs. So I think that is also very promising. So if we conclude from bench to bedside, I think spinal navigation with radiation-free 3D imaging is definitely possible. I think intra-op bone MRI, that is still far away for us. It's very rare that theaters are equipped with intraoperative MRIs, but nowadays there are some, mostly for brain tumor surgery in pediatrics. But if you would like to rely on pre-op 3D imaging, you can use a bone MRI and combine it either with point cloud surface matching or 3D printed guides. At least with those techniques, we have tested it and validated that those combinations are actually safe and quite accurate techniques. So in conclusion, MRI-based synthetic CT combined with spinal navigation is feasible, and it is non-inferior to conventional CT for safe and accurate insertion of pedicle screws, and radiation-free spinal navigation in pediatric spinal deformity that should be definitely explored. Thank you.
Great job. Thank you, Dr. Schlosser. Really exciting work. We do have a question submitted by Dr. Stefan Parent. A very interesting study. How do you explain the difference in angulation between the planned and actual position? Is it actual error of placement or surgeon bias?
It is actual error because for the thoracic and lumbar study and also for the cervical study, we stored the position of the drill guide during the surgery. So it's actually a comparison between the position of the drill guide intraoperative, where the surgeon thought he was bullseye, with a postal position of the K-wire. So these are not a surgeon error, it's the error of the combination of the imaging modality combined with the navigation technique.
Thank you. Got it.
And maybe I can add that the resolution of the CT as well as the bone MRIs, they are around 1 millimeter, just below 1 millimeter, 0.7 millimeters. So you would expect a maximum accuracy of around 1 millimeter because that's the accuracy of the imaging modality.
Thank you. Dr. Little.
Thank you. That was a fantastic talk and very interested with the synthetic CT as well. It's amazing, particularly in pediatrics. Regarding the accuracy in the cervical spine, I was wondering if that's related to any of the training of the neural network. Has it been trained for the cervical spine? Do you think there is any improvements there, or it's fundamentally due to the anatomy?
It's fundamentally due to the anatomy because the accuracy is more or less similar to the thoracic and lumbar spine, but the cervical pedicle screws are definitely not more forgiving because of the anatomy, because every important structure is just more close. Actually, the first validations in the spine for the synthetic CT generation were performed on the cervical spine, and later the lumbar, and the last the thoracic spine, which had to do with air artifacts with the lungs around the thoracic spine.
Thank you. Okay, we'll go next to Dr. Baas.
You're muted.
Oh, you're muted, Dr. Baas.
Sorry. Thank you for your work, and I'm really very interested with this work. And what do you think are the barriers for clinical implementation of the MRI in the operating room, really?
So using the pre-op 3D MRI?
Yeah.
So there are some practical barriers. So actually all navigation systems, they only now accept DICOM files that are labeled as a CT. So we also still have some tricks to convert the bone MRI into a CT. We label them as a CT before they can be imported in the navigation system. So that is a practical issue, and actually that also took some discussions with our pediatric radiologist, because then there is a scan in the PAC system which is actually MRI, but it is now labeled as a CT.
Thank you. Very interesting.
Dr. Swarup.
Hey, Tom. Nice paper. Quick question, and you went over this, but I just wanted to make sure I understand it. Can you talk again about the actual MRI sequences that you're obtaining? And is that protocol kind of publicly available, or are most radiology departments able to do that reliably across the country or across the world?
Yeah, so that protocol is possible on the three major suppliers of MRI machines in the world. So GE, Siemens, and Philips. So and it is like a T1 sequence, and that is publicly available, those sequences. And the cloud-based conversion by the AI network that is now being commercialized.
Got it. Thank you.
All right, I don't think we have any more questions. Thank you, Dr. Schlosser. Very exciting work. I just had one last question. How widely used is navigation?
So I'm largely biased because I generally do not use navigation, but because we now have the bone MRI available for every AIS patient, I obtain a bone MRI. Well, previously I only obtained it for patients that had neurological deficits pre-ops or atypical curves, and now with this available and also a shortening of the MRI protocol, I think it's really valuable to have a 3D image of each vertebra pre-operative to do your surgical planning. And whether you use navigation or not to perform the pedicle screw placement, I think that is really surgeon dependent.
Got it. Great. Thank you. Wonderful. Okay, well, today we heard from all of these amazing individuals who are grant recipients from the SRS. And as chair of the Research Promotion and Oversight Committee, it is really our responsibility to ensure we're creating awareness on the impact of all of the great research work that the SRS funds. There's grants given in over $300,000 annually from the SRS. This would not be possible if we didn't have the amazing support from industry sponsors and incredible donations from society, surgeon members, and healthcare providers. So thank you to all of you. And thank you for all of your presenters today and participants. Amazing questions. And I definitely learned a lot. I hope you did as well. Please don't forget when the webinar ends, a little quick survey will come up. Please do complete it because that's going to help us improve these in the future. That's all we had. So have a wonderful rest of your Saturday, or good night to Dr. Little, who's probably tired at this point. So thank you so much. And thank you to Becca and Lara from the SRS for making this incredible webinar happen. It's our 5th year and very proud to be a part of it. Thank you.